Good morning, good evening, and good afternoon. Thank you so much for this great opportunity to present with one of the most eminent neurologists in Egypt and a great advocate for the case of MS and a very good friend and dear to my heart, Zakaria. It's really an honor to present with you. I'm talking today about access to treatment from the patient organization perspective. And the title of my talk is, or our talk is, When Railway Tracks Meet. The tracks meet with no accident, actually, so don't worry. It's just we're reaching the same destination. When we are having the same goal, it's eventually we are reaching the same destination. Why parallel tracks? By parallel tracks, I mean the patient organization and the medical community. I represent the patient organization in this presentation, and Max Zakaria is representing the medical community. And why were they parallel? Because the challenge back in 2004 was the acceptance of the medical community to a patient organization. It was far 17 years ago when we're talking here about a little bit of a different generation. And it was difficult for the whole community, not only the medical community, to accept the patient organization because it was the first and it is still the only patient organization in Egypt. And why access? Because when we started early in 2004, we realized that no matter how hard we work in awareness, in information, to seek more employment opportunities for people with MS, psychological support sessions, it meant nothing or maybe less important to them than getting treatment. It was really unaffordable treatment that was there, and little number of people were really on disease modifying treatments back then. So we realized that our first aim will be access to treatment to people with MS in Egypt. And as we were then the voice of the patients, we took this from the perspective of the case. So for the case, and in order to present your case, you need to prepare your documents first. And this was the first and most challenging step in the journey. So I'm talking about a journey of 17 years now. So preparing your documents was the first challenge and the most maybe tiring of all the steps that will follow. You have to know your judge. Who are you presenting your case to? You have to bring the evidence and wait for the sentence. Before you go to the court, we were, as I told you, a very new organization to the community. It was just one person back in 2004. This is Ahmed Darwish. He is a great person with progressive MS. And now we are having 24,000 people. So back then in 2004, we need to have a reputation or the image to sell our case. So we were like the salesman. We need to have to work hard on our internal structure, the organization itself, the board, the logistics, the registration, the headquarters, the website, the number of people. We worked hard on reaching out to more people. The media ties, our ties with the medical community back then, that some of the eminent neurologists were coming to our meetings as instructors. They were taking care of this patient education program that we were holding. The pharma, the ties, it was very important to be standing at the same distance with all pharma companies back then. And the international engagement, especially World MS Day, which was a great advocacy tool to our organization. So building up your image to people, you sell your image to the community before you reach for the judge. In the form of interviews in the televisions, in newspapers, so many meetings. We visited the universities. We took care of the children of people with MS. We went to schools. We went to McDonald's to distribute our brochures, to talk to people, to the public. And we were a very important part in Cairo Runners, and this is the biggest event for runners in Cairo. And we were always there talking to people, especially young people, raising awareness about MS. So we had to make a big noise in the community, to be recognized as the patient organization and the voice of people with MS. This was a very important step as well, building up history with the Ministry of Health, with the government. So back in 2011, after the revolution, the Egyptian revolution, we realized that there was a shortage of medicine. So we contacted all the global industry asking for treatment. And we got a huge amount of vials from one of the disease modifying treatments. And we had the choice to have this treatment in our possession so that we could give our patients whenever they need. But we decided to give this to the health insurance organization so that it will be more organized. Only the needy will be given the treatment. And by this move, we had this history with the health insurance. So it was one of our values that we were really convinced that you give something before you ask for something. And it was a very crucial point in our relationship with the health insurance. Also, this step was very important because it added to our reach out to people who are not part of the MS Care Society back then. So they are now getting to know our organization. So we could collect data from the patients, and we started our very beginning in the patient's registry. Preparing the documents, the evidence, this was very important. As we realized that now we started to have data, social data and financial data about our patient. And the numbers are very important because numbers don't lie. The facts about MS, we started to have some proofs and evidence-based medicine about the age of people with MS in Egypt, how many with recurrent remitting MS and how many with progressive, the impact on the productivity of people with MS. We had also to seek for scientific evidence of the importance of early treatment, market search. We knew the geographical distribution of people in Egypt who are covered with health insurance, who are not. What is the financial burden on the families? And we had two important publications with Max Zakaria about the financial burden from the social point of view, of course. We also seek the cost, the direct and indirect cost. And as the patient organization, we were very clever in selling the concept of caregivers. It wasn't mostly known, this caregiver concept and the burden on the caregivers and the absenteeism from work and the productivity effect of MS, having a person with MS in your house and the effect on the caregivers as well. So the cost was very important thing and a very important part in our case. We also need to know our judge. So our judge is not judging by if we have a fair case or not, because we knew very well that our case is fair. Who can argue with the patient's right for treatment? But the point is, your judge is now talking about reimbursement. So it's a financial issue. You need to know that it's about the cost. And we dig much about who are we going to talk to. The Ministry of Health, of course, the health insurance organization, we already had a good history with them. And we came to the Central Administration for Pharmaceutical Affairs. And this is an important structure because they are concerned with pricing and with the approval of medicines. So these are the three, the ministry and the central administration and the health insurance, they were our targets and they were the judges we should have been talking to. So what do we do in order to address those people? We searched for a friend from within. This friend is very important because he will lead us to the person on charge, the budgets, their plans. We also seek some information from the pharma about the past experience in pricing and approving of other medications for other diseases in Egypt. Now it's the time for us to bring all the evidence, the data, the numbers to the judge in order to give his sentence. We had our hard proof and our soft proof. the evidence should be very precise in order to get you directly to the decision. You don't need to be trapped into ups and downs or misjudgment or any jargon in your negotiations. And always remember that garbage in, garbage out. The judge usually does not have the luxury to listen or to see all your heaps of documents, and you don't have the luxury to leave him like the blind man and the elephant. So we focused on certain questions. So what benefit does it bring if they reimburse the medicines? To which patients exactly? The recurrent remitting or early progressive people, or what kind of patients? How would it fit to these healthcare system priorities? Is it worth it, the cost benefit? And the quality of life. We were really good at talking about quality as well, which is the number of years that people with MS live in good health. This is a different concept than just the quality of life. We had to talk about social exclusion, divorce, discrimination, unemployment. And the live evidence was very useful, and we really depended much on the young people. Who can say no to a pregnant young lady, or a student in the university that he is very hesitant to leave the university because they were covered then they were receiving their medicines in the university. So when you say that he has to choose between his health and his future, it's very touching. And you also teach those people, train them to present their case, to talk about the distance they have to be close to the toilets all the time at their work. How is treatment affect their productivity and improve their life and their social life? And sometimes you also depend on some of the human rights organization. They are very clever at demonstrations and so on. So we did not initiate a demonstration in Cairo, but when we were asked if it's okay to go for one of the demonstrations for MS, and you never say no to this. Okay, we don't join, but we don't say no, actually. So when we take the evidence, the hard evidence and the soft evidence to the health authority, remember also to acknowledge the question you're asked and the effort already made before by them. Bridge to your key messages. Always stay focused to your message. Don't be shifted or distracted to any other way. Conclude with the proof. Always remember that bring the numbers, bring the benefits that they are going to be. These people are young people and they need to have a good life, and this is going to affect the national product at the end of the day. And when you feel successful, dangle and deliver for the next case. Usually, when you have unfavorable reply or the sentence is unfavorable, you usually get it on the spot. But if it's going to be favorable, they usually need some time to see their papers, their budgets, and then they will come to you later on. Always remember that you never lose. You either win or learn. And the learnings to our patient organization was that access is the gem of the patient's needs. No matter how hard we work on the awareness, on employment, or anything else, it always remains the access is the most important need for the patient. It's also interrelated aim because it works in every kind of aims, other aims like research, like advocacy, like communication, like capacity building, because we had to work hard on our capacity building as an organization in order to get this reimbursement and access to our patients. Always remember that working together with the medical community, with the pharma, with the media, with the government was very useful, and it took our steps further forward than if we were working alone till now. And that's it for our patient organization perspective. And now I'm going to handle the talk to my very dear friend, Mike Zakaria, for the medical community's perspective.
Thank you very much, my dear colleague Mai, for this very interesting presentation about the journey of the MS Care Society through the Egyptian MS community. And I must confess that we have learned as physicians a great deal from our colleagues in MS Care, especially Mai. There are many things that were totally outside the scope of our thinking, and we started to realize these things when we started the close cooperation with MS Care Society. And I'm honored to have Mai with me today to talk about the Egyptian experience. Now, talking about the access to medication, we know that for any medication to be cost effective, the cost effectiveness threshold in low to middle income countries like Egypt should not exceed 3 times the gross domestic product per capita. In Egypt, this gross domestic product per capita per year would be $8,700. That means that if we want to introduce any kind of high efficacy medication, this will not fit unless these pharmaceutical companies would provide us with huge discounts. Now, the problem is, are the pharmaceutical companies ready to do this? Yes, they are ready to do this if there is data from the region, because they cannot start initiating anything if there is no data. And also, there should be clear pathways for the diagnosis and management of MS. And again, they should have, and most of them actually have, patient support programs in order to help the countries with economic problems by giving them discounts. So we need all these three criteria in order to convince the pharmaceutical companies to go down with their prices to the level of the 3 times the gross domestic product. Now, all this needs specialists. They need neurologists in order to understand the field of MS and collect the data and have clear pathways. And this is the problem with Africa, that most of the African countries, they don't have neurologists. In fact, only 11 countries have more than 10 neurologists, 11 countries among the continent. And there are many African countries who do not have any neurologists at all. So if we want to make use of the experience of, let's say, Egypt in Africa, then the first thing we start to establish is to establish education and neurologists. This is the main problem. These will collect the data. Now, this was the situation in Egypt before 2012. We had many eminent physicians. We had a long history of local research, but the people who taught us, they were not interested in international publications very much, and they were not interested in collecting data. So there was always the deficiency of documentation and no international publications, no specialized centers, and of course, there was no Ministry of Health coverage of all the medication. Although historically, we have professors who have been talking about MS in Egypt since 1954. But to the international community, Egypt was non-existent. No data, no international publications. In fact, in this review article by Hani Ben Amir, who was one of the British neurologists interested in epidemiological studies about MS in the Middle East, the frequency and clinical patterns of multiple sclerosis in Arab countries, this was 2009. All the Arab countries are there except Egypt. So Egypt was totally out of the international scope because there were no data and publications. After 2012, there was a change in the landscape of MS in Egypt because we started to perform dedicated MS units, to establish dedicated MS units, where the main objective was to document data, clean data, the data that is correct and complete and accurate. And a new strategy was set forward, services, of course, integrated services in these MS units. The university units were the first specialized units in MS, the university units. And we started afterwards to establish other units that are not university units in other less privileged areas. Of course, training to the young neurologists in order to be MS specialists, and publications, research, international publications, and of course, patient education. The first MS unit was in Cairo University in 2012. And this Cairo University MS unit, this is the team, now comprises more than 2,500 patients, files for these patients. The second one was Ain Shams University unit, 2013, and currently has more than 3,500 units. Other university units were established, and the main aim was to document what is missing. The patient services, of course, managing the patients, giving them medication, changing the medication, following up the investigation, and the MS registry, which was the beginning of our databases, and of course, training and scientific activities. And this is an example of the registry, the sheets for the registry. We had hard copies for the patients, and we had electronic copies on two systems, the IMED system for the MS base and the MS network for our national Egyptian registry. Of course, the MS units worked in collaboration with the different specialities, the neuroradiologists, the clinical pathologists for the labs, the CSF examination, ophthalmologists, rheumatologists, nephrologists, and of course, physiotherapy. So we had integrated services in these MS units. And currently there are 6 university MS units and more that are not university units now across the different regions of Egypt. Governmental support was zero in 2011, as Mai was talking about, but reaching full reimbursement of all of the medication nearly of MS until 2019. Now, how did we do this? As Mai said, we convinced them with the economic models showing that in the early stages of MS, even if you pay a lot more in the medication, then you can save a lot in the later stage from the indirect costs. So treating patients with an EDSS of 2 would be less costly than treating patients with an EDSS of 6.5. And of course, this was coupled by the ability of the pharma when they saw the data, when they saw the change that happened. This was coupled by them giving us prices that are affordable by the government. So it was both directions. For the government, the economic model that if you leave the patient, then you are losing money, not gaining money. And also the pharmaceutical companies seeing the change that has happened and the data collection, they were ready to give discounts. Of course, the cooperation, as spoken by Mai about our society, with the MS Care Society, with the medical community, a very fruitful communication that has been lasting for many years now. And we had a lot of patient awareness meetings in cooperation with MS Care and online engagements, even before the era of the COVID. Now everybody's talking online in the era of the COVID, but actually we had movie stars in different universities, our university, Ain Shams, Cairo University, Mai's University. We had different MS specialists that are movie stars and continuing the online communication with the patient, even 24/7. I don't know how they have the time actually to do this, but they actually are doing it. And because we became established centers for MS, Cairo University, Ain Shams University, we were participating in many of the phase 3 international trials. And we even developed a national registry in cooperation with the different MS centers that are, of course, university centers mainly. And we established this national registry in 2015 with some of the sheets, the baseline sheets, the follow-up sheets. They're all electronic networks seen on the MSS, www.msnetwork.eg.com. And currently we have 5,245 cases. And we actually entered the MS Data Alliance with the MS network. They are our network, the Egyptian network, is currently in the EMIF catalog of web-based registries. Now we established an Egyptian protocol for management of MS. Of course, we had high efficacy medication, but we were not aiming at abusing the resources of the government with these high efficacy medications. So we had to establish a protocol for treating MS patients in which we have the different categories, and each medication fits into whether it's active, highly active, or aggressive, but not using the high efficacy medication that are expensive in all patients, and so abusing the resources and maybe trapped in not having enough money to continue. And this is an example of our treatment algorithm. We have medication for CIS. When we talk about active relapsing remitting, we start with the first line therapies. Failing, then we go to fingolimod, then ocrelizumab, and we can shift from active relapsing to ocrelizumab if we have criteria of aggressive relapsing remitting. So we are mainly keeping the ocrelizumab for the aggressive cases. We can use it from the start if you have the criteria that this patient is going into an aggressive stage, even if it's treatment naive. And this is also the logarithm for using ocrelizumab, mainly aggressive, even treatment naive, but aggressive with bad prognostic or poor prognostic factors. And if the patients are non-responsive to first-line medication and they show also prognostic factors of aggression, or if they fail fingolimod or have serious side effects from fingolimod. Then came the publications, of course. Unfortunately, a country like Egypt, the first international publication in a specialized MS journal came in 2015, the first one. But since then, the track opened, and all the time we're having new international publications. These are some examples, and showing you how many we have now in the, we have changed a lot since 2015. And we entered the international registry, the MS base, which has 35 countries and has been working since 2002, I think. And currently, Egypt is number 7 in the patient enrollment by country with 3,600 cases, although we have only entered the MS base 2.5 years ago. And we have now reviewers for the international journals. We have people in the editorial board. We have managed to be in the Atlas of MS 2020. So we have seen a lot of change in the course of management of MS in Egypt since 2012, starting from reimbursement to the establishment of the MS units with the full documentations and the database and the guidelines and the international publications and local, national, international registries. And of course, the most important is the cooperation with the MS Care Society and the patient societies, because this really has changed the way we think about things. And altogether, we changed the mindset, building integrated community and media sharing, negotiating with the government on a win-win base, showing that they won't lose, but in fact they might save money if they treat the patients. And the pharmaceutical companies started to see the achievements, whether local or international, and the existence. So they started to we were able to press them hard to go down to prices that do not exist in any part of the world. And of course, research came out, and we cooperated with the patients organization deeply. And as I said before, we learned a lot of them, and it all ended up with teamwork. And I think this teamwork, whether with the physicians, whether with the patients' organizations, whether with the pharma company, even with the government and the governmental institutes, all of us were players of the same team. And we managed to achieve something in Egypt that is, in my personal mind, something beyond believing that it could be achieved in a low to middle income country like Egypt. And of course, all our junior staff that dedicated themselves to achieve this and to help in achieving this, I would like to greet them all, and thank you very much for all your attention.